Vedolizumab and anti-integrin therapy in IBD. Vedolizumab is a monoclonal antibody that specifically targets the 4,7 integrin, a key molecule that directs lymphocytes to the gut by binding to MADCM1, an adhesion molecule uniquely expressed in the intestinal vasculature. By blocking this interaction, vedolizumab prevents immune cells from migrating into the intestinal tissue, making it a gut-selective therapy that minimizes systemic immunosuppression. Although its exact mechanisms may also involve modulation of innate immune responses, and some immune cells can still reach the gut via alternative pathways, vedolizumab has demonstrated significant clinical efficacy in both inducing and maintaining remission in moderate to severe ulcerative colitis, UC, and Crohn's disease, CD. Integrins, such as 4,7, are cell surface receptors essential for guiding leukocytes to specific tissues by interacting with cell adhesion molecules, CAMs. In the gut, 4,7 integrin binds to MADCM1, directing immune cells to the intestinal mucosa, while E7 integrin helps retain these cells within the epithelium through binding to E-cadherin. In IBD patients, elevated levels of 4,7 positive leukocytes and increased MADCM1 expression contribute to ongoing inflammation, as these immune cells release pro-inflammatory cytokines like IFN, TNF, Illinois 17A, and Illinois 9, exacerbating tissue damage. Anti-integrin therapies like vedolizumab work by disrupting these integrin-CAM interactions, thereby reducing the influx of inflammatory cells into the gut and alleviating inflammation. Vedolizumab is approved in both the US and Europe for patients who have not responded adequately to conventional treatments or anti-TNF agents. Its gut-specific action is advantageous in reducing systemic side effects often seen with broader immunosuppressive drugs. However, challenges remain, including the high cost of treatment and limited efficacy in some individuals who exhibit primary non-response, secondary loss of response, or intolerance. Additionally, vedolizumab does not directly target the existing mucosal inflammation but rather prevents further immune cell migration. Ongoing research aims to better understand these mechanisms and develop alternative or complementary therapies to improve outcomes for IBD patients. Here's a rephrased and combined summary of the information on JAK inhibitors for IBD. JAK inhibitors in IBD treatment. Janus kinase, JAK, inhibitors are a class of targeted therapies that block JAK enzymes, key players in immune signaling pathways, to reduce cytokine-driven inflammation in both Crohn's disease and ulcerative colitis. By inhibiting JAK activity, these drugs prevent the activation of STAT proteins, thereby decreasing the production of pro-inflammatory cytokines and dampening the immune response within the gut. Several JAK inhibitors are approved or under investigation for managing moderate to severe IBD. Tofacitinib, Xeljanz targets JAK1 and JAK3, approved for moderate to severe ulcerative colitis, effective in inducing and maintaining remission in patients who have not responded to conventional treatments. Its oral formulation offers convenience compared to injectable therapies. Upadacitinib, Rinvoq, a selective JAK1 inhibitor approved for moderate to severe ulcerative colitis, showing efficacy in refractory cases for both induction and maintenance of remission. Filgotinib, another selective JAK1 inhibitor currently being studied for both ulcerative colitis and Crohn's disease, with early results indicating potential benefits for moderate to severe disease. Advantages of JAK inhibitors include their oral administration and targeted mechanism of action, making them effective options especially for patients who have failed traditional therapies or biologic agents. However, these drugs carry risks such as increased susceptibility to serious infections, e.g., tuberculosis, pneumonia, potential for blood clots, particularly with tofacitinib in patients with cardiovascular risk factors, and possible liver or kidney toxicity, necessitating regular monitoring. There are also concerns regarding a potential increased risk of cancers like lymphoma with long-term use. JAK inhibitors are generally reserved for patients who do not respond adequately to conventional or biologic treatments and require careful patient selection and ongoing monitoring to mitigate risks, especially avoiding use in individuals with active infections or certain cancer histories. Future directions and precision medicine. Finally, integrated data approaches combining